Hi, everyone. I'm Monica Soni, Associate Chief Medical Officer at New Century Health, which is also part of the family with Vital Decisions, which does telehealth advanced care planning. I spent most of my career in the safety net system and public systems on the delivery side, really thinking about how to serve historically underserved populations. And I'm thrilled to be here with a couple other illustrious physicians. So I'm going to pass the mic over to Dr. Aiken to please introduce yourself, and then Dr. Simpkin.
My name is Paul Aiken. I'm the Senior Vice President for Population Health and Chief Medical Officer at AVMed, and that's a regional not-for-profit health plan in South Florida. I've been an advocate of advanced care planning, and that's based on first personal experience and then professional experience, and that's been pretty much throughout my career. And I've always been an advocate of the ethical principle of autonomy, people being able to make informed decisions, and that's a really important part of clinical care. And I think that advanced care planning really has its place in shared decision making and promoting patient autonomy and maximizing the number of choices that people have to guide their own care. So I'm a big proponent and fan, and appreciate the opportunity to be with you today.
My name is Henry Simpkin. I'm a family physician with Valley Medical Group in Northampton, Mass. I've been in the same job for 36 years, and the reason why advanced care planning and end-of-life decisions is so important is that I've realized that we all die, and we all should discuss this. And if it's left out of the conversation, we're missing a really critical part of a patient's whole trajectory. And so we can't forget about this.
Well, thank you both for being here. We're sort of lucky because we've got the full spectrum of healthcare system players. And I'm going to get us into sort of a meaty topic first, which is, super buzzy right now to talk about value-based care. There's a lot of money flowing in this space. We've talked about advanced care planning as being sort of a moral imperative, if I can rephrase some of what you all have mentioned. How does money connect with that? So tell me, maybe Dr. Simpkin, I'll start with you. How do you think about advanced care planning as even fitting into a value-based care framework? Does it or does it not?
So I'm reminded of work I did with the Institute for Healthcare Improvement, where the whole point was better care. Value-based care is another name for better care. And so if you can measure the value side of it with money, you're still talking about better care. So it just seems so clear to me that advanced care planning dovetails with all of that easily. It's better care for the patient, but I think it's the patient who feeds that back to us. Thank you for discussing these important things with me. And maybe I'll stop there and get Paul to say something.
Thanks, Dr. Simpkin. Yeah, I totally agree. Value-based care, I agree. It's the trying to get the right care at the right place at the right time for the right reason with the right provider, and all of that supports a better outcome for patients. And so there's a parallel, right, with advanced care planning, because it too it's about empowering the person to make their personal choices and have them followed if they're not able to speak for themselves. But so it's really an alignment. It's a natural alignment, I think, between the purpose of value-based care and the purpose and intent of the advanced care planning, so that we get that alignment, and between the provider and the patient, and so that the menu of choices can be outlined, and that patient, member, customer, person can choose from among the menu of choices in terms of what they would like to what sort of care they would like to receive. So again, it's about autonomy, supporting shared decision making, and really ultimately improving the quality and outcomes as defined by the patient, really.
Dr. Aiken, what do you say to folks that suggest that the health plan doesn't have a space in this, that this is between, practitioner and patient on the ground level, and that insurers just want to make a buck, and this is sort of a sneaky way to make a buck?
Yeah, I don't agree that it's a sneaky way to make a buck, and I don't see that as what the health plans are looking to do. I think the health plans are really looking for that, with value-based care, right? The right care. Health plans want the right care for people, and despite being notorious for just saying no, there is an appropriate time and reason for not covering things if they're not proven to be the right time or place or purpose. But there's also the flip side of that, which is leaning into yes. And I think health plans are recognizing and supporting this notion of identifying what services patients should be getting and have not been getting, and try to help identify those gaps and try to highlight, for the providers that the gap exists, and can that gap be closed, and can the health plan do anything, to help do that. So I think that we really do want to cover the services that have been shown by evidence to work, and advanced care planning through evidence has been shown to be very effective, and that's for people who choose to have them. And the health plan is not, forcing anybody to do anything. We don't force anybody to get any care. And so we're not forcing anybody to get advanced care planning. We're deciding whether it's going to be covered and how to, close gaps for those who may want to have it, but haven't been able to access it. So, I do think that cooperation between the health plans and the health systems in these value-based agreements can also support, and then helping to fill gaps where they exist. So
this is a really important point, Paul. I think that I want to drill down on, which is that there are gaps in our healthcare system. Yes, there are things that patients are not getting that, on the provider side, Dr. Simkin, there's too much, right? There's a number of studies that show that there's too many tasks, there's too many preventative services in a given day. You cannot do it for the panel in front of you. And so you have to rely, yes, on team-based care within the walls of the clinic, but other folks like the insurers and the payers to help you actually, like that. Everybody has a role to play. And so I think that's a critical part to kind of pull forward, is you can't do it alone. We've proven in the healthcare system that we have been unable to do it on the delivery side alone. And Dr. Simkin, maybe you can just piggyback on this and share, you talked a little bit about once the billing codes dropped, all of the conversation changed within the walls of your clinic, even though you had been doing this for decades and decades, not all of the providers had. Tell us more about that.
So clearly having a billing code for advanced care planning put a light bulb in somebody's eyes, in a CFO's eyes, to say, here's income that we can generate. The question that came to our committee was, how can you convince your colleagues that this is worth one more conversation and that this is an important thing? And so our committee sort of pulled together clinically to say, this is why this stuff is important. Would you, when Atul Gawande's book, Being Mortal, came out, I thought it was a really important support for this whole concept. Are we discussing the realities of people's lives with them? Are surgeons saying, should I do this surgery, or are you really so much at the end of your life that would be inappropriate? And I guess a philosophy that I've had most of my life is, if you are doing everything that a patient needs and wants over the course of their lifetime, when it comes down to the end of their life, you can offer a different perspective. And they're not thinking, oh, but he never did anything for me during my life. They're saying, this doctor has done everything I've ever asked for. And he's coming back and he's saying, shouldn't we talk about palliative care? shouldn't we talk about end of life issues, not because I'm trying to help them die faster, but as Paul pointed out, this is the appropriate time for a detailed conversation about their wishes, and what they want has to be included in this whole process.
So important. I always have felt as practitioners that support adult patients, absolutely integral to what we do is thinking about death and dying with dignity, right? It's that full spectrum. And maybe other folks in the, other specialties don't think about it in that way, but I absolutely have. And so we would be remiss if we weren't actually thinking about wishes, caregiver experience, the bereavement experience. I mean, this is absolutely along the continuum of what we need to be doing. And to the earlier point, you can't always do it all. And so priorities shift based on where there are dollars and what funds other services and, what the quality metrics are. I mean, you can pick any number of things, but that is what sometimes drives behavior, within the walls of the delivery system. And I think we just have to kind of be eyes wide open about that, or else we're being a little bit overly naive. Let me ask both of you one last question before we close out this segment. There is still some stigma out there, I think, around this idea of dollars connected to services in any way. Can you just talk about, what would you say to folks that sort of pose that question to you? And is it just the reality of the American healthcare system, or is there some different and better way to be thinking about that tension?
Patients that I talk to about end of life issues want to talk about end of life issues. They aren't interested in the dollars. The patients aren't. If the health plans are seeing dollars as part of this, I would say that it's a positive response to this complicated problem. How do we give doctors the time to talk to their patients about the stuff that they want to talk about? So you're reimbursing the doctors for an important topic that the patients know is important. Like with my work with IHI, performing better medical care and getting better medical outcomes also should be financially better for a system. Better medicine should be better financially for a system. And I would say the vast majority of the elders that I talk to about this are more apt to go to palliative care or have their wishes recognized, and that's going to be saving money on the end. So my career has been about putting the money where my mouth is up front, so that at the end of life I can say, do you really want to do this? And they know that my wish is for them to have the best outcome possible. They know that I'm not interested in saving money on them. But all the stuff that came out about the death panels and stuff, I think that was a huge overreaction to something that most patients are very, very willing to discuss.
I very much agree. I don't believe there should be any stigma really attached, and payment for service is payment for service. So advanced care planning is a service that supports that alignment between the patient and the provider. It gets at rendering the services that the patient is looking to receive, and just like any other services that a patient would be looking to receive, a cardiac catheterization or an immunization or any other service, it's a service of healthcare, and like every other service of healthcare, there's payment associated with it. And so I don't see a stigma associated with any other payment for service, and I don't think that there should be one for this one. I kind of like, I don't know if maybe I've coined a term, but the quintuple aim. And so really, this gets at the quintuple aim, right? And so it does, we are looking to improve the care and the outcomes of that care for members, and as defined by the patient, by the member, by the person, and create a better experience. Better experiences are had by people. It's been demonstrated for those who choose to have advanced care planning and receive palliative care and maybe hospice services. For those that choose it, evidence shows that they appreciate that service and take that course themselves and have, as challenging as it might be, or difficult as it might seem, but there is such a thing as the good death. There is a pathway out of this life that can be less miserable than other choices. So anyway, so that's experience. And then the cost of care. It has been shown that for people who choose palliative care services and hospice care services, they're not using those by choice. They're not using some of those other higher cost services, and so that does impact cost, and it does bring it down. Again, that is part of the quintuple aim, and so I think we can just say that it does bring down cost, but that's not the sole intent. It's all of these other components of the quintuple aim. And so the fourth is really looking at the social determinants of health, and I think there's a component that a cross reference between advanced care planning and some of the social determinants of health and other challenges that people face. Are they able to choose get the right care at the right place at the right time, and do they have this available to them as well? Is that an equal footing across the board for this service? And then I think the fifth part of the quintuple aim is improving end-of-life care and end-of-life outcomes. So I think it's one straight line of opportunity to improve services, improve outcomes, and do so in a way that respects resources that are financial resources that are of course limited.
Yeah, that framing is maybe what I'll close this out on, which is this is evidence-based medicine, and we are comfortable paying and reimbursing for evidence-based medicine. And there is more evidence behind this than all sorts of crazy other things that we do in the healthcare system that we tolerate, in every specialty and every site of care. And so to me, to have this be more controversial than things that patients receive that don't make them live longer or better and are costly and are dangerous to do is very backwards to me. And so the more we can sort of lift the curtain behind that and share the experiences that you all have shared and the wisdom you all have shared, I think the better that we are. So thank you for your time. We will be back to talk more about this topic, and I really appreciate you being so candid with this difficult topic.